Assalamu alaikum. I welcome you all on CME weekly CME session. We'll start today's CME session with the name of Holy Quran. I will request Qari Maqsood to come on stage and recite few verses of Holy Quran.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. إذا جاء نصر الله والفتح ورأيت الناس يدخلون في دين الله أفواجا فسبح بحمد ربك واستغفره إنه كان توابا. صدق الله العظيم.
Jazakallah. Well, I am the presenter of today's CME session. Let's start with the today's topic. It's basically a case series which was different cases percutaneous nephrolithotomy which was carried out in AFIU. So multiple cases are there. In a year we did perform 2000 cases in a year. So I asked my mentor, Colonel Qamar Zia is my mentor at that time. He is the only examiner in Pakistan for FRCS. He is the only one examiner. I asked, sir, I will present your case in our CME. He did allow me. So it's a good honor for me to mention his name before his name in Gilgit Baltistan. He was very pleased this type of sessions should be conducted in all over Pakistan, and Gilgit is also. So Mini-PCNL a day case surgery. In case number 1, 38-year-old male which was presented with severe left flank pain, having no fever. Serum creatinine was 1.1 mg per dl. His HB was 15.4 gram per dl, and WBC was turned out to be normal. This is the CT KUB plane which shows radio dense shadow in the pelvis which was measuring 3 into 1 approximately centimeter, representing a stone in the left malrotated kidney. Patient had IVU, the control film, and the contrast urographic phase film. You can see the anterior displacement of the pelvis and the lateralization of the upper ureter in the left side, and then medialization. This is basically the malrotated kidney. So malrotated left kidney with 3.5 cm solitary stone in pelvis. A left DJ stent was placed to control the pain. A patient was in his kidney was in obstruction. So upper pole puncture using Mini-PCNL was used. There are 3 techniques which was used in PCNL, percutaneous nephrolithotomy. One is upper pole puncture, second is gradual descent technique, and third one is the bullseye technique. There are 3 types of techniques for approaching the kidney while puncturing, approaching the stone while puncturing the kidney. So in this picture you can see the sheath inside the renal calicial system, a guide wire and ureteric catheter, and complete clearance of stone in the left side of picture, and endoscopic view of stone and partial view of stent as well. So Mini-PCNL, you can say it's a day case surgery. In this regard, we have only single stitch after such a huge surgery. So outcome in this surgery, you can see the post-op X-rays where ureteric catheter and digestant are in place, and there was no shadowing, no radiodense opacity in the left flank. So operative time was 70 minutes. There was no blood transfusion. His chest X-ray was clear. Chest X-ray was performed, usually performed in upper pole punctures, as there was a risk of blood in the pleural cavity, hemoperitoneum. So 100% clearance was achieved. Patient discharged on next day after removal of ureteric and urethral catheters. Case 2, a 34-year-old male treated for left ureteric stone with URS and left DJ stent placed for 14 months back in district hospital. He was experiencing left loin pain, intermittent hematuria and UTIs. His KUB X-ray shows stent with extensive incrustation. Here you can see in the bladder portion of the stent there was incrustation, and the whole ureter, almost proximal and the mid of the ureter, which is totally incrustated, and you can see the upper end of the ureter also incrustated. So the whole DG stent was incrustated with the stone. But this type of DG stents with stones are very challenging to treat. I am expressing the same two cases here in Gilgit. So we are lacking the available. Obviously, in the government setup, we are having no endoscopic instrument. We all are aware about this. So in private setup, I am doing this type of cases. I did remove a DG stent with almost near to same position. Initially performed the cystolithopexy for the bladder stones, then the ureteric stones. Then I sent patient to the swath for PCNL just to remove the incrustation of the upper part of the kidney stone. So initially cystolithopexy, stone from the bladder is removed, and lower end of JJ stent. Then URS with intracorporeal lithotripsy along with the length of stent was performed. Then ESWL, extracorporeal shockwave lithotripsy for pelvic tail stone, 2 sessions was performed. Removal of attempt but still failed at that time. You can see the lower ureter and the turn of the bladder stones are clear after cystolithopexy and lower URS. So for this type of scenario, the Mini-PCNL was obviously the choice of modality at that time. The first picture you can see the Calicial system of pacification. This process is known as Calicial system of pacification. In this, what actually we do is we just introduce a ureteric catheter in prone position. We just introduce the ureteric catheter. Then contrast urographin, which was introduced, and under fluoroscopic imaging, we used to the calicial anatomy should be organized. Like this one is the lower pole calicial system, and this is a mid pole calicial system. We approach to the most lateral calyx. This one is the sheath inside the calicial system, and this part is the stone basically. And this is a final picture after PCNL. There was no shadowing, only ureteric catheter and sheath of the PCNL is inside doing the calicial system. We at FIU we do perform pediatric urology as well. So a 3-year-old male child presented with a large vesical calculus and 3 centimeter left renal calculus underwent vesicolithotomy for bladder stones 6 weeks back, booked for Mini-PCNL left. Further plan, obviously once the stone from the body is removed, then after 4 weeks we do screen patient in early age of stone disease. So this is the picture, 3D picture, which shows the bladder stone here, kidney stones. So almost a complete stagon stone, and here is the bladder stone. There's a KUB stone, CT KUB plane. Whole pelvis is filled with the stone and the lower pole stone as well. So this one basically is the sheath. This whole instrument is the nephroscope, and this is the light source, and here is the irrigation, and you can see whole of the system is introduced through single port, like sort of single approach. So Sir Kamar and Dr. Saif, he was senior to me. Dr. Sher Shah, he was junior to me at that time. Stone in the pelvis. This one is the ureter, the left stagon calculus, lower pole puncture was approached, then mild contrast extravasation seen, calculus completely fragmented and evacuated. Here you can see again the Calicial system, the most lateral was approached. This one is the LP needle of 18 gauge. Initially under the fluoroscope guidance we approached through the LP needle. Once we are in the Calicial system, we introduce guide wire through this LP needle, and LP needle was removed. Over single step dilatation, we introduce, this is the initially the metallic dilator, then sheath is introduced. This is a final picture, the ureteric catheter, it was a complete removal of the stone. So patient had GA, 4FR ureteric catheter was used, prone position, lower pole puncture, single step dilatation, 14FR sheath use, operative time was 45 minutes, complete clearance was achieved, blood loss was minimal, only ureteric catheter retained, smooth recovery, patient discharged on second post of the age of this was a complete stagon stone. Very challenging stones to treat in horseshoe kidneys. This was a 7-year-old boy. This is the pelvis anteriorly lying. Here is the Calicial system. This was the isthmus part, which is connected to the lower other lower pole of the kidney, contralateral side. Here is the ureter. We approached. This was the guide wire, and is the single step dilator introduced into the Calicial system. No. So you can see the patient data. January 16, December 17, 1000 of cases was performed. Mean stone size was 3.1 centimeter. Upper pole excess was 39%. Lower pole excess was 58%. Simultaneous upper and lower pole excess was 0.14. This type of simultaneous approach for complete stagon stone, which was performed in same setting. The stone types, stone in horseshoe kidney are less likely, lower pole stones, then renal pelvis stone. Most of common location of the stones are renal pelvis stone, then partial stagon stones. Procedure data, mean operative time was 67 minutes, mean hospital stay was 22.3 hours, clearance rate was 93.3% overall. The mean hospital stay, in complete stagon stay, there was increased stay in hospital almost 42 hours. Rest of the kidney stones, there was 21 to 22 hours. In hospital readmission cases, renal pelvis stone less likely, 0.8%, lower pole 1%. In complete staghorn stone, these type of complete staghorn stones are always challenging. So 1.7% of the patient were readmitted. So in post-op complications for such huge number of surgeries performed in year, according to Kelvin Dindo system, grade 1 injuries, grade 2 and grade 3 were in a range of 1.5 to 2%. Transient fever most commonly 3.4%, then elevation of creatinine, that is transient as we give trauma to the kidney. So the transient elevation of the creatinine is 0.7. Then blood transfusion 1.1%, pneumonia is 0.4%. Angioembolization, in 3 years training at AFIU, I have seen only 3 patients post PCNL, they underwent angioembolization, and luckily their kidneys were rescued. The patient for angioembolization, the patient is very initially there was difficult monitoring. There was a huge bleeding through the severe hematuria. Patient HB was dropped to 2 to 3 even. Then massive blood transfusion was required, and patient was shifted in interventional radiology, end up in angioembolization, and some second day patient was 100% okay. So it's a very rare complication that kidney bleeds post PCNL. Then DJ stent 1.8%, chest intubation 0.6. Chest intubation is most commonly occurring in upper pore punctures. For complete staghorn stone, we did double punctures, lower pole simultaneously. Then there is a need of chest intubation. I have never seen a patient of nephrectomy or bowel. Yes, there is a bowel injury, especially nowadays PCNL is performed in spine position. For spine position, there huge risk of bowel injury. Just we approach from the mid-axillary line. In patient is partially spine and approach from the mid-axillary line, then there is a chance of bowel injury. I never seen a nephrectomy to be done for a patient post PCNL. Sepsis 0.4%. Grade 5 and grade 4 injuries are very rare in PCNL settings. So for residual stones, as PCNL got 93% clearance rate, there is still chance of residual stones after PCNL. So 55 patients underwent ESWL and 18 patients were subjected to redo PCNLs. This 1,000 cases in 24 months. This is the whole data for partial, complete renal, pelvic, lower pole and horseshoe kidneys. Their hospital stay is 22. For complete is a number in hours, 3 days almost, and 21 readmissions, blood transfusions, angioembolization. All these was said before. So come to the conclusion. Mini-PCNL is a safe as day case surgery except for complete staghorn stone. Then less operative time, less traumatic, less blood transfusion as compared to open surgery, and safe in pediatric age group obviously. Then results are comparable with any national or international institute. Kelvin 4 and 5 complications are very rare in PCNL settings. Thank you, and your questions are welcome. This study was basically presented in UK, but yes, my consultant, I was part of that team in multiple surgeries of PCNL. I did ask, sir, मैं जो है ना ये आपकी presentation है CME में present करना चाहता हूँ, तो he was very happy कि जो है ना आप बिल्कुल करें. He is now serving in Malir as a full colonel, HOD of urology. So he was very appreciated. Like आप लोगों ने एक साल में जो है ना 1000 PCNLs किए हैं और बड़ा अच्छा आउटकम और उनकी कॉम्प्लिकेशन सारी जो है ना सर. तो ये बेसिकली स्टडी यूके में प्रेजेंट हुई थी. ये पूरी आर्टिकल है बेसिकली ये.
So what are the reason of incrustation of the
Yes, incrustation is just
reasons क्या है?
रीजंस इसमें सर ये है कि एक तो फॉरेन बॉडी है. फॉरेन बॉडी नेवर एक्सेप्टेड बाय बॉडी, पहली चीज़. सेकेंडली एक डीजे स्टंट, हर डीजे स्टंट की एक लिमिट होती है बॉडी में. लाइक यहाँ पे गिलगित में जो आजकल हम डीजे स्टंट यूज़ करते हैं, दीज डीजे स्टंट शुड बी रिटेन फॉर ओनली 2 वीक्स. अगर इसको हम 3 to 4 वीक्स कर देते हैं तो वो बेसिकली जो उनका बायोफिल्म होती है, बायोस्टैटिक फिल्म होती है, बायोफिलिक फिल्म होती है, वो डैमेज हो जाती है. वो डैमेज हो जाती है तो एंड अप इन ऑब्स्ट्रक्शन, अगेन ऑब्स्ट्रक्शन, फिर स्टेसिस और फिर स्टोन फॉर्मेशन. तो जिसने 6 वीक्स के लिए स्टेंट रखा था, आप लोगों की पेशेंट थी यहाँ पे, डॉक्टर इमरान ने सर्जरी की थी पहले, उनकी जो है ना वो स्टेंट निकाल ही नहीं सके. मतलब इतनी सीवियर इनकस्ट्रेशन हुई थी. तो उसकी रीज़न ये होती है कि यहाँ की स्टेंट्स की लाइफ बेसिकली कम होती है.
वजह से है, इट इज ड्यू टू स्टेंट और ड्यू टू द पेशेंट रिएक्शन टू द
रिएक्शन नहीं, बॉडी रिएक्शन टू द स्टेंट एज, क्योंकि उसकी लाइफ एंड हो जाती है. अब जो दूसरे कुछ स्टेंट ऐसे हैं जो ईयर के लिए होते रखते हैं, जिसमें रेट्रोपैथ
6 महीने भी हमने यहाँ पे रखा.
Exact.
6 महीने के बाद भी निकाला,
निकल गया था वो. उसमें ये होता है ना कि सर के स्टेंट की जो फॉर्मेशन होती है डिफरेंट, उसके ऊपर फिल्म्स यूज़ होती हैं. अब रेट्रोपेरिटोनियल, इडियोपैथिक रेट्रोपेरिटोनियल फाइब्रोसिस आपने बिल्कुल सुना होगा नाम. उसमें क्या होता है कि यूरेटर्स को बायलैटरली जो है ना वो जंबल अप कर देता है, उसको पकड़ लेता है, जिसकी वजह से सीवियर हाइड्रोनेफ्रोसिस होता है. उसकी हल ये है कि आपने सर्जिकल के अलावा आपने उसमें डीजे स्टेंट रखना है लॉन्ग टर्म, जस्ट आपके किडनी पेटेंट्स रहें. तो ऐसी कंडीशन में स्टेंट्स बनते हैं जो ईयरली चेंज होते हैं, मतलब साल की रहते हैं, उसमें कभी नहीं बना. तो ये बेसिकली जो स्टेंट फॉर्मेशन होती है इसकी वजह से इंक्रस्टेशन होती है और बॉडी का रिएक्शन अगेंस्ट टू द फॉरेन बॉडी.
मतलब ये बिकॉज ऑफ द स्टेंट
इटसेल्फ, बिल्कुल इटसेल्फ.
मतलब बास स्टेंट्स की जो है रिएक्शन टू द
बिल्कुल.
रिएक्शन इज वेरी हाई.
बिल्कुल ऐसा होता है. और स्पेशली फीमेल्स में बनने का ज़्यादा चांस होता है. और हाई वेस्कुलर जो ये जो कंसनट्रेटेड यूरिन होता है, जो स्टोन फॉर्मेशन है बेसिकली, क्रिस्टलाइजेशन होती है. कंसनट्रेटेड पहले यूरिन होता है, फिर सेडिमेंटेशन होती है, फिर क्रिस्टलाइजेशन होती है, फिर इन्यूक्लेशन होती है, देन स्टोन फॉर्मेशन होता है. तो डिहाइड्रेटेड यूरिन से ही काम स्टार्ट हो जाता है.
What most frequent and most common post-PCNL complication you observed in your experience?
Yes, in AFIU I have seen patient came with high grade fever, sepsis. In literature there is also written that 3.4% of the patient end up in a sepsis. Fever, they came with fever, bacteremia, just because there is a reason for this bacteremia. We go for stone, we just laser it, we just pneumoclast it. Then stone is basically a component of bacteria. Nidus, basically a nidus for bacteria. If we break the stone, there is all of a sudden bacteremia to that system. If the organism enters into the blood, appropriate antibiotic and appropriately not treated, the patient landed with the sepsis. इसीलिए सर हम करते थे वहाँ पे, the prerequisite for PCNL is ideally patient should be infection free. For every PCNL we did perform urine culture and sensitivity, and he should ideally be negative for the culture. He should have been for 7 days antibiotics before entering into the theatre for PCNL. Thank you.